Good morning. I want to thank Amila and the Council for inviting me for this lecture. This is a very large area, the endophthalmitis, but it is a very important area. So I'm trying to concentrate on few important points. When we, when you're talking about the endophthalmitis, we know that there are a lot of studies, mainly medical management of endophthalmitis, but when you concentrate on, we mainly depend on the one study which was done in 1995, which is published in 1995, that is endophthalmitis vitrectomy study. So most of our management is still based on this study with certain modification with the development of ophthalmology. But we can't forget our basics that because we have to tailor our management according to the certain things. Mainly when we are talking about the endophthalmitis, the organisms is the most important factor. So we should know what are the most common organisms in our setup. So the endophthalmitis we see in many situations, mainly the post-operative endophthalmitis, then post injections, then following the trauma, and in endogenous endophthalmitis. When we talk about the post-operative endophthalmitis, the most common organisms are the bacterials, and of these, gram-positive bacteria are the most common, and gram-negatives are not uncommon. At the same time, we see a lot of fungal cases as well in some settings, especially ICU and patients we receive from medical grounds. So when we talk, the bacterial pathogens are, when we talk about these bacterial pathogens, and we go through the other details from world, other researchers and studies which were done, all shows that gram-positive cocci are the most common. But if you go through this, you can see that in some Asian setups, gram-negative bacilli also not uncommon. So when we tailor, we are in this group, so when we tailor our management, we have to think about what antibiotics or what we are going to start according to these details. So in addition to that, other types of endophthalmitis is also very important. One thing is delayed or chronic post-cataract surgery endophthalmitis usually arises after 6 weeks. These are the characteristics. We see a lot of patients of this category as well. After about 6 weeks, sometimes somebody brings with a chronic endophthalmitis. The diagnosis is sometimes straightforward feel like, but the thing is that these patients straight away, they respond very well to steroid. So sometimes we think some sort of inflammatory process, uveitis, what we were talking in previous sessions. So, but sometimes it is not uveitis, but it is a chronic endophthalmitis. Anyway, we have to do cultures and other things to exclude. But the other important point is some other situations also appear like this. We'll talk about them later. But when it comes to the endogenous endophthalmitis, predominantly, most of the time we see fungal cases, and some cases bacterial etiologies also we see. Then endophthalmitis without reaching the eye wall, that also we have seen. Don't forget that. Sometimes we think that after scleral buckling, which is not penetrated one, or after contact lens keratitis or post-LASIK, we see cases like endophthalmitis. So yes, it has been shown and it has been reported that cases following without breaching of the sclera. So our assessment, I'm not going to discuss the assessment, but assessment is very important. Why it is important? Because you see that this is the response what we see in many cases. Actually, you can see that how cornea, anterior chamber, iris, and you can grade the inflammation. Why grading is important in these cases? Because there are some reasons for that. Because you can see that you see that. These are some of the slides shown in some researchers. Now, when the grading is high, more inflammation, you can see that the culture positivity is high, because there's a what sort of like more streptococcus infections are more, and more severe cases you can identify at the point of patient at the when the patient comes to you. This is because this is very important when we talk about the endophthalmitis. We don't have a diagnosis, laboratory diagnosis at the starting point. So we start with uh, clinical diagnosis. So this type of like a categorization is very important. So then you can decide your management until like while we are waiting for your laboratory diagnosis. In addition to that, some situations we are not sure whether this is endophthalmitis or not. So most of the time, what we see is the TAS, toxic anterior segment syndrome. Sometimes we misdiagnose as endophthalmitis, and at the same time, other way also. Sometimes we think it is TAS, but actually it is endophthalmitis. Because of these things, we should know what is TAS and what is endophthalmitis. Usually, in many studies done in EVS and the ESRS, they shows that these, most of the time, endophthalmitis patients, they have reported that they have pain and redness much more than the TAS. The TAS, the pain is less, but you can see high intraocular pressure at the presentation, and TAS appear very quickly. So because of these things, little bit we have to be, when we start in the treatment for endophthalmitis, we have to make clinically, there should be clinical judgment whether we are dealing with which type of case. Then what are the diagnostic methods? I'm not going to discuss about all the diagnostic methods, but current standard is vitreous step. So vitreous step is not that easy sometimes when we come to the practical situation. Why? Because many times you might have come across that there's a dry tap. We are unable to aspirate. In that case, what we do? We can actually, as a vitreoretinal surgeon or a general ophthalmologist, there's no difference. We can use a single port. We can see when we just vitrectomy cutter, single port, and go in and take out some. But at the same time, if it is not possible, we can go for anterior chamber tap, which is like a 32% yield rate, while vitreous tap usually double of that. So then, sometimes we come across culture negative when we do vitreous tap, but we see a culture negative. Why do we see culture negativity? Culture negativity is due to many reasons, but sometimes it may be our own reasons like small sample size, delay in processing, our laboratory problems and things like that. In addition to that, other things like infections with unculturable pathogens and things like that. So we can use advanced diagnostic techniques which are practically not available in many times, which is not available in our country, but still we should know of this polymerase chain reaction. PCR can be used. Then the newer one is whole genome sequencing, where it gives better results than the PCR. So whatever the thing, basically we take the specimen, we work up, and we expand our workup if it is not positive. But most of the time in our setup, we treat them. So these are the commonly used stains and the culture media in our setup. So this is what we see in our slides. If you have gone through, we see like staph, pseudomonas, and other organisms and fungals. I'm not going to discuss about. So when it comes to whatever the thing, we have to start treatment. We have to treatment before you come to before laboratory tests come into your hand. So most of the time we have to cover gram positives, so we use vancomycin, and ceftazidime has a wider coverage, so we use ceftazidime. So this is it. Some situations, like if it is we suspect like an ocular trauma or fungal endophthalmitis, most of the time we use voriconazole, but amphotericin B can be used. But nowadays voriconazole is we know that it's better because voriconazole even oral bioavailability is higher than the others. So, but we should know that when it comes to the intravitreal antibiotics, there's the difference between the toxic and the therapeutic concentration is very low. So always we have to keep it in mind because we have seen many cases. I want to show you this slide. Actually, this is how resistance appeared many years back to now. 2005, vancomycin is 5%. In 2015, still the vancomycin maintained a good. That means better, the resistance is less. But when it comes to the other, ceftazidime, you can see that 2005 is low, but now it is resistant is 62%. So it is, we have to keep it in mind that when we are treating this patient, because sometimes it may be the patient is not responding, one reason is this. Then when we treat them with the vancomycin, just this example, you can see that in this slide, first day, when we give intravitreal vancomycin, the concentration is 179, which is exceed the MIC. But second day it goes to 72, and third day it is negligible. That means that when you give intravitreal vancomycin, if you want a response, sometimes you have to re-inject after 48 hours to 72 hours. The other thing is ciprofloxacin. Ciprofloxacin we use as oral. Yes, it's a very penetration is good. But when you see that, it is like most of the time, sometimes we do prophylactically, but you see that uninflamed eye, it is a concentration build up within the vitreous is very low, but inflamed eye, it gives a good MIC, so which is required. So in some setups, they use in post endophthalmitis cases like ciprofloxacin, or nowadays we use even moxifloxacin 400 daily dose, which is then what is the rationale for systemic antibiotic? When it comes to the systemic antibiotics, you see that this red line is the intravitreal antibiotic, what you see there. So when we give intravitreal, we create a good MIC, then it gradually goes down. While we start the systemic antibiotic, so it gradually goes up. So which build up intravitreal concentration with the systemic antibiotic. So this point, it crosses over and it maintains the MIC what is required. So this is the argument of using systemic antibiotics in some situations. So this diagnostic workup, I'm not going to work, but there's another important point I want to discuss about the inflammation cascade. So we know that this is an infection related to microorganism, but at the same time, microorganisms, they produce a lot of toxins. There's a fibrin matter, and it damages enzymes and other components which damages retinal tissues, because retinal tissues is very sensitive. So what will happen is, so when are we going to use the steroid? In this research, you can see that, this is a rabbit done on rabbit, you can see that here the vitrectomy done without the steroids, and here you can see the retina well preserved with the steroids. So effective intravitreal corticosteroid, we know that there's some situations we use intravitreal corticosteroids in endophthalmitis. But when it comes to the fungal endophthalmitis, we have to be very careful because it can aggravate the situation. One thing is impairment of the antifungals. Second thing is interference with the immunogenic response, result in aggravation of the condition. So vitrectomy of endophthalmitis management is sometimes advantageous. Nowadays, we straight away go for early vitrectomy. EVS study, the vitrectomy is delayed, or they did only the co-vitrectomy. And they didn't recommend full vitrectomy because of the fragility of the retina. But nowadays, that later on CEV study shows that complete vitrectomy is more beneficial. Why? Because you know that this is the newer cutters, you can see that we can go very close to the retina, even we go on the retina, and we can do a better vitrectomy. So we are very safe. So we go for the cases. Just I want to show you one case, which is a case you can diagnose that this is a case of endogenous endophthalmitis. So I'm not going to, this is how we manage this type of endogenous endophthalmitis with the fungal. I think time is over. Thank you very much.